Hello, 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 everybody. Can you hear me and see me? Amazing, amazing. So I'm just looking at the group at the moment, the WhatsApp group. If you can see us, please say yes, we can see you. This is the PLAB 1 Revision 2025 WhatsApp group. Lovely to see you all coming for this webinar. We're going to give about maybe a minute more for everybody to join this webinar and to ensure that you guys all join this WhatsApp group. If you have not already, this is the time to scan this QR code to join. Very shortly, we'll introduce ourselves and we'll get started. So we're just going to make sure that everybody's in. Scan the QR code. Good, good, good. It's so nice to see so many of you here today, a few hundred of you here today on this free 1 hour webinar. Good. I can see a lot of people joining that. Amazing. Okay. So perhaps what we'll do is we'll introduce ourselves and then we'll come back to this front page just so everybody can join the WhatsApp group again. All right. Now, I'm Z. My full name's Wei Zian Zito. I'm a GP, and I work in London. I work in the NHS, and I'm still working in the NHS. I've been working in the NHS since 2016, so that's about 9 years. And prior to that, I was working as an obstetrician. I think I had about 3 years of obs and gynae experience before training as a GP. My initial hospital that I worked in the UK was St. Thomas when I came in, guys in St. Thomas. And I've got lovely memories there. I trained in palliative care and A&E. And during my first placement in London as a new international medical doctor, right, I met Adam Jakes, who at that time was SHO in Obs and Gynae. And Adam, please introduce yourself. Oh, Adam, why can I not hear you?
Hi, I'm Adam. I'm a consultant in obstetrics and gynecology. However, before that, I was working as a medical registrar, having gone down the MRCP route. I trained Z and taught him everything he knows. He was a fresh international medical graduate. I took him under my wing. I bought him a nice shirt. I showed him where to get a nice haircut, and ensured he was well looked after in the UK.
So just for clarity, everybody, Adam was at one point my junior. So he was under my sort of a obstetric lead. I had to like, hey man, this is how you do a C-section, Adam Jakes. And now look at him, he's a consultant obstetrician. Amazing times. Go on, Adam.
Thank you, Z. This is my introductory slide. But yes, me and Z have worked together for a long time, supporting and building up PLAB and developing the 4-day revision course, the big mock exams, the webinars, building on resources that we felt would benefit international medical graduates going for the PLAB exam. And the PLAB exam is still a super overpopular process of getting into the UK. And despite what you're hearing, there are plenty of jobs and plenty of people coming to the UK for working within the NHS. So do not be put off and do not be waylaid by what you see in the headlines.
Good.
So, me and Z are going to give you a sample of kind of what we teach, how we teach, what kind of resources we offer. And it's good fun as a good introductory of how to approach the PLAB exam.
Lovely. So I'm just going to go back to this very first page because I know a lot of you have not already joined the WhatsApp group. We're going to wait here 20 seconds. Quickly take out your camera, scan this QR code to join the WhatsApp group because this group is how you are going to be asking us any questions during this webinar. We will be addressing some of your questions, not all of them, because there are a few hundred, it's close to about 900 of you, isn't it? So we really need to move on to the questions that we think are relevant. But if you do want to ask us something else, and you're more than welcome to message me or Adam privately as well. We are on this group. Join this WhatsApp group and let's get cracking. Now, if you don't have time to scan this QR code, don't worry. You can still find this WhatsApp link on your Zoom confirmation emails as well. All right, let's get cracking. So the PLAB exam has 180 questions. Again, it's a pass or fail exam. So what this means is that you don't need to get 179 questions correct, right? You just need to pass. And usually the average score to pass is about 117, right? So if as long as you pass the exam, you're good to go. No one in your future interviews are ever going to ask you and say, hey, did you pass with a high grade or not? No one's going to ask you that. As long as you pass, you're good to go. So, what we'll be doing today is we'll be going through some questions just to give you an idea of what we do in the course and also help teach you medicine. So, this is the first question. We're going to give you about a minute to answer this one, and I'm going to launch a poll here for you to answer. And there you go.
So you might need to, depending on what you're using to join the webinar, you might need to move the poll out of the way or minimize it. But this is quite a common question in the PLAB exam. And so you may be familiar with it, you may have even seen something similar, but it's a key element that you must know about. And as Z says, you've probably got about 50 minutes, 50 seconds to a minute to answer each question. And therefore, you must answer. You never skip a question. You must always give an answer, ideally by a minute, either answering and then coming back to it, but never leaving it.
All right.
Amazing. So let's go through the question together. So I'll just end the poll and just share with you kind of the distribution of results. But actually, it doesn't matter what everyone else is doing. It's all about how you answer and get it right. And so if we just go through the question, look, you've got a 71-year-old woman who has chest pain radiating to the left arm, shortness of breath, and then you've got your answer straight away when the ECG demonstrates ST elevation. And so the appropriate management of anyone who has ST elevation is primary coronary intervention. It should be a learned response. If you see a STEMI, you go primary coronary intervention. But remember, when you take on practice questions, people lose the value because they think, oh, I know this one. This one was easy, or I've seen it before. That's not the whole point. Remember, next slide, please, Z. Remember that each question is an opportunity to continue to expand. For example, it's quite common in the exam for someone to ask, okay, which element of the heart or which blood vessel has been occluded in this acute coronary syndrome. And so leads 2, 3, and AVF tend to be the inferior myocardial infarction, which is a right coronary artery, more associated with heart blocks and bradycardia. What you give as the absolute initial part of the management of acute coronary syndrome. Well, I'll talk about that in a moment, but it tends to be morphine, metoclopramide, oxygen if hypoxic, nitrates, and aspirin. And so I even criticized the question, probably written by Z, saying, where's the aspirin? Yeah. And then I go through the actual options. Am I familiar with them all? So thinking, okay, well, how is low molecular weight heparin monitored if required? What on earth is alteplase? Warfarin is a nice one because we know it is a vitamin K antagonist, which inhibits factors 2, 7, 9, 10, protein C, protein S. We don't use warfarin in pregnancy, these kind of things. And we know that when it comes to the heart, clopidogrel is very, very seldomly used with only certain special cases, which I'll discuss in a moment. But I'm just highlighting that seeing a question once before and just throwing it away or saying it's easy is not the right approach. Take a question, pick it apart, dissect it because it has so much learning. And that's what we focus on in the course. So, as I said, it tends to be there's always a question, one per exam, based on cardiac anatomy in the context of acute coronary syndrome. So, if you have your ST changes in your leads 2, 3, and AVF, that is indicating there is ischemia in the inferior aspect of the heart, which is associated with the right coronary artery. And the right coronary artery supplies the SA and AV node. And so you're more likely to have bradycardia or heart blocks in that context. The lateral aspect of the heart is where you see ST changes in leads 1, AVL, V5, and V6. And that is the left circumflex artery. Whereas your ST changes in your anterior septal area are going to be your left anterior descending artery. Memorize this slide, burn it to your brain. It's important, it's so key. Obviously oversimplified, but this is what comes up in the exams. So then you think, okay, I've got a patient with acute coronary syndrome, which in all intensive purposes is unstable angina and NSTEMI and STEMI. All patients will get morphine to reduce venous return and decrease cardiac workload, and metoclopramide to not only reduce the rate of nausea and vomiting. Oxygen if the patient is hypoxic. There's no benefit in giving oxygen if the patient is not hypoxic. Nitrates again to reduce venous return, and a nice bit of chewable aspirin as an antiplatelet. All patients will get these likely in the ambulance, but this is your initial first line treatment. And then in our patient, which had ST elevation, we gave the Mona morphine, metoclopramide, nitrates, aspirin. And then the answer would be primary coronary intervention. Put a stent in that occluded blood vessel. Yeah. Now, many people focus on, oh God, what if it's 12 hours from the onset of pain? Or, oh God, what if primary coronary intervention cannot be delivered within 120 minutes? What planet are you living on? These things are outside the scope of the PLAB exam. Thrombolysis has been demonstrated to be inferior to primary coronary intervention. And in what context can you not give the gold standard of care of primary coronary intervention within 2 hours? Unless you're on the moon, in a submarine, hidden in Z's basement, the key thing is primary coronary intervention is always the answer with STEMI, unless clearly demonstrated so. So many people will see a question and say, I haven't been given the time since they got pain. I haven't got the time how long they've been in hospital waiting for it. Completely irrelevant. That's not how the PLAB exam works. What it's assessing you is, are you a safe doctor? Do you understand that ST elevation? You identify it on the ECG. That could be a question in the exam. You identify the location and blood vessel by where it is on the ECG. That could be another question. You get asked about the initial treatment, which will be your Mona. And then, of course, your appropriate, your best, your gold standard is your primary coronary intervention. Be very cautious of choosing thrombolysis unless it literally tells you the patient's waiting in the corridor, can't get in the door because it's locked, or they're trapped on the moon. Do you give them thrombolysis? It is not only inferior, but it doesn't come up in the exam. And don't you dare worry about people who have had a STEMI, chest pain, but they finished watching their TV program for 12 hours. You know, they watched Breaking Bad or Lost or anything like that. No, it just doesn't come up. So STEMI equals primary coronary intervention. And the gold standard second antiplatelet for anybody who gets primary coronary intervention or an acute angioplasty, you give prasugrel. So not only are they getting aspirin, but prasugrel as their second antiplatelet. You can see with a STEMI, there's no clopidogrel, there's no fondaparinux or low molecular heparin. It's really straightforward. Mona, primary coronary intervention, prasugrel. NSTEMI and unstable angina. And remember, you must know the difference between them. With unstable angina and and NSTEMI having the same ECG changes, but what you don't get is a rise in your troponin with unstable angina. So you must be able to differentiate them. With unstable angina or NSTEMI, the same approach, MONA, morphine, metoclopramide, oxygen if hypoxic, nitrates to reduce venous return, aspirin, nice chewy aspirin as an antiplatelet. But this is where it differs, and the PLAB exam loves when you can differentiate management is that you give fondaparinux, which is basically a synthetic low molecular heparin, for 5 days or up until they get the angio. So that's the next appropriate step following diagnosing of an NSTEMI or unstable angina. So what could come up in the exam? Well, they could ask you about identifying it on the ECG, the ST depression, T wave inversion. They could ask you where in the heart, which blood vessel is affected. That's another question. They could ask you about treatment, which would be MONA, followed by fondaparinux. And then it's also good to understand what on earth happens next, which is where the patients get risk stratified using the GRACE score. You do not need to know what the GRACE score is, but you do need to know that patients get risk stratified into conservative management. They do not get an angioplasty in the hospital. They get treated conservatively. They get given ticagrelor as a second antiplatelet, and then they're seen as an outpatient compared to those that are high risk. Yeah, they get an angioplasty within 72 hours. Yeah, so you get the fondaparinux, then they go for their angio, and then because we're doing an acute angioplasty, their second antiplatelet is not ticagrelor, it's prasugrel. Yeah. So that is a bit of a lower yield, but understanding how we differentiate the higher versus the low risk ones and what do we do. And what's interesting is the different antiplatelet, depending if they're going for an angioplasty or not. And then just the little sprinkles of additional bits. Well, clopidogrel or clopidogrel, however you want to say it, is only now used in the context of acute coronary syndrome when a patient is on warfarin or a DOAC. So if your patient has atrial fibrillation and is already on a DOAC, we're going to give aspirin, but then we're not going to give that second antiplatelet of ticagrelor or prasugrel. We're going to use clopidogrel because we have much more data about the use of clopidogrel and other antiplatelets and anticoagulation. So that could be a nice potential exam question. Patient on atrial fibrillation on a DOAC comes in with a STEMI, you still give MONA, but instead of giving ticagrelor or prasugrel, you're going to give clopidogrel. And then after everything's sorted, you get your lifelong aspirin, you get your second antiplatelet for 12 months, which would be your prasugrel if it's a STEMI, a ticagrelor if it's a conservatively managed NSTEMI, or clopidogrel if you're on warfarin or DOAC. You get an ACE inhibitor to help with cardiac remodeling, as well as a beta blocker and a tasty little statin. And then the final thing about acute coronary syndrome, to get your head around everything that you should know about this, is driving restrictions. Because if you've treated the underlying cause, you've done a successful angioplasty, then they only need to stop driving for 1 week. But if the angioplasty was unsuccessful, I wasn't able to properly stent it, or they were treated conservatively as an NSTEMI, it's a 4 week driving restriction. So I've given you a whistle-stop tour about acute coronary syndrome, but I'm just highlighting the nice slides that we developed, really nice summary slides. Also, my role is to stop you going to the nth degree because remember, the PLAB exam is a shallow but broad exam. You're not being tested as a cardiologist. Even if you're a cardiology senior doctor in your own country, the PLAB exam is assessing a resident doctor level, not specialized. And so you do not need to go to extreme levels or complexity. It's mainly going to be based on guidance and how each condition is managed accordingly. So I hope you enjoyed that little whistle stop tour. I've talked enough now. Let people rest.
All right, next question. Just gonna relaunch the poll there. Great. Stopping the poll in three, two, one, ending the poll. Now sharing the results there, and of course, A is your answer, everybody. Reassure. This here is a reflex anoxic seizure, right? The main thing that differentiates it from epilepsy is that it's brief, it's less than a minute, and there's no post-ictal phase. Now, everything else you don't even need to remember, right? The main thing is that when you see reflex anoxic seizures, you just need to reassure. The trigger is usually a sudden fright, pain, or shock, like a little child suddenly seeing Adam for the first time, and he's like, and then they get this vaguely mediated brief asystole, right? And they turn pale, and then the child stiffens and goes limp, and sometimes has these brief jerks, right? And this is important because I think a lot of candidates think that jerking must be epilepsy, but that's not true. Jerking can happen with reflex anoxic seizure. It can also happen with breath holding spells. The importance is looking at the duration of the seizure. If it's less than 1 minute, realistically, it's not going to be your epileptic seizures in the exam. And especially if there's no post-ictal confusion, right? In epilepsy, when the child wakes up after maybe 3, 4 minutes of a seizure with jerky movements, sometimes it takes them 20, 30 minutes before they are fully alert. Whereas with reflex anoxic seizure, they come back again almost immediately. Unless, of course, they see Adam's face again and then they go back into a reflex anoxic seizure, right? So, what's important for this specific topic? A lot of candidates actually waste a lot of time trying to differentiate between reflex anoxic seizure and breath holding spells. And while we do sort of give you an idea on our revision gems or on gems about the differences, what we try to concentrate on is that you don't really need to know the differences. As long as you can tell that these are not epileptic seizures. Because the main thing that question writers are going to ask you is, how do you manage this? And all you need to know is it's reassurance. So whether the trigger is anger, frustration, where you're thinking, oh, maybe this is a breath holding spell that the child turns blue. Again, blue is more of breath holding spells. You don't need to know all of that. You don't need to differentiate in a reflex anoxic seizure and a breath holding spell. So don't waste time reading into that. All you need to do is recognize that brief loss of consciousness, jerky movements, following some anger, frustration, or shock, right? And with no post-ictal confusion, the management is reassured. Now, this is a very important question. I think that, if you get these easy ones out of the way, the chances are you're going to pass your exam. So make sure you go for the ones that you know are free marks almost. Moving on. Next question.
Right, here we go. Another bit of kind of ECG cardiology, but such an essential kind of concept. So that's coming up to 60 seconds to take on this question. Make sure you commit. So if we just stop the poll now and share the results, you can again see a huge variety of questions, highlighting where people are different places of their revision. And so, in essence, this is a patient who's come in where you're concerned that they've had a pulmonary embolism. And many people have read the textbook and chosen S1Q3T3, which is a pathognomonic sign on an ECG. However, it is not the most likely and by far very rarely seen, and is definitely not the correct answer here. The correct answer is actually sinus tachycardia, which is by far the most likely finding on the ECG. Z, if you just pass, move on the slides, you have one roll. No, too far. Go back. Go back one slide, Z. You fruit
There we
me.
go.
Yeah. So if we go through the options there, so, most common finding by far is sinus tachycardia. S1Q3T3 is pathognomonic. And so the most specific sign is, yes, S1Q3T3, but rare as hell. It's not going to be the option. You could have a normal ECG, but it isn't the most likely finding. And left axis deviation or T-wave inversion is going to be your kind of heart strain in big, severe PEs. And so, again, not the most likely finding. Remember that last line in the question really captures what the question is actually asking you. Yeah. So this was to try and trip those up. Maybe you haven't managed somebody with a pulmonary embolism before. Maybe you've not seen S1Q3T3 before, but you've read it in the textbook. But the key thing is common things are common. Don't look for zebras in a field of horses. Sinus tachycardia is by far the most common finding. So when it comes to diagnosis of pulmonary embolism, in those who are not pregnant, the gold standard is going to be your CTPA because you can literally visualize thrombosis or identify any lung pathology. Yeah. Invariably, you do a chest x-ray prior to any definitive testing because you want to rule out the other causes of this presentation, like pneumonia, very common finding that would mean that a CTPA wasn't indicated. Or you might find a pneumothorax or a pleural effusion. And so, of course, a chest x-ray to rule out all that simple pathology that doesn't need a CTPA. And a CTPA, as I say, is the gold standard. VQ is very rarely used in the context of a non-pregnant individual. But it's important to know how a VQ works. In essence, um, you need a normal chest x-ray to be part of that ventilation measure, comparing to the perfusion. So a VQ scan, not commonly used outside of pregnancy, and you must have a normal chest x-ray. While in pregnancy, what we're thinking about, we're concerned about radiation to the fetus and inappropriate investigations. Now, if somebody comes in short of breath but has a big swollen leg, of course, ultrasound the leg because not only is ultrasound very easy accessible, but it has no radiation. So that's easy. But if they don't have a big swollen leg, but they've come in short of breath with pleuritic chest pain, you must do a chest x-ray to again rule out pneumonia, pneumothorax, pleural effusion. Yeah. And remember, a chest x-ray is completely safe in pregnancy. It is always done if indicated. It's not even thought of a second if it's needed. If you would do a chest x-ray when they're not pregnant, you would do a chest x-ray if indicated when they're pregnant. You never think more of it. But if the chest x-ray is normal and you still think, oh God, this person likely has a pulmonary embolism, the first thing you do is give them treatment dose dalteparin or low molecular weight heparin because low molecular weight heparin doesn't cross the placenta. And actually, these investigations can take time. So, as soon as you suspect a pulmonary embolism in a pregnant person, you give them low molecular weight heparin and then you arrange definitive testing. And there's no guideline to recommend which is the best definitive test in a pregnant woman with a consideration of a PE. But a VQ scan has less radiation to the mother's breasts and a little bit extra radiation to the baby, while CTPA has much more radiation to the maternal breasts and less radiation to the baby. Now, if you think about who is your primary patient in pregnancy, it is the mother. And so, actually, you do not want to significantly increase her lifetime risk of breast cancer, given that in pregnancy, the maternal breasts are undergoing significant cellular changes. And so, a VQ scan is the most appropriate first line investigation for a pulmonary embolism following a normal chest x-ray to rule in or rule out a pulmonary embolism, given that there is less radiation to the maternal breasts. A CTPA is also appropriate. However, VQ scan would be what we would recommend choosing if given the choice.
All right, next question. Remember, if the poll is blocking your screen, just close it. You can reopen it later by clicking those three dots on the bottom right of your mobile screen if needs be. Good. Stopping the poll here in 3, 2, 1. Sharing the results. The answer is A. So this is a confusing question to some extent. But let's just break this down a little bit. So this is a patient with a 3-month history of gradually worsening shortness of breath and persistent cough. So this is chronic. Yeah. This patient has rheumatoid arthritis and has been taking methotrexate for 10 years. 5 years of methotrexate, 10 years of having rheumatoid arthritis. The spirometry shows the FEV1 that's low and the FVC that's low, and FEV1 FVC ratio that is higher than expected. So this here shows a restrictive condition, not an obstructive lung condition. This is a restrictive lung condition. Before I address this, let me just go through this with you again, right? So remember, with restrictive lung conditions, you can expect the FEV1 and FVC to be low, but the FEV1 FVC ratio to be either normal or high, right? With obstructive conditions like COPD or asthma, you would expect the FEV1 to be low, FVC to be normal, or at least more than 80% of predicted, and FEV1 and FVC to be very low, less than zero point 0.7. And with obstructive conditions, the two most common ones are asthma and COPD. If it reverses, that's your asthma. If it doesn't reverse, that's your COPD. Well, with restrictive conditions here, we are primarily thinking about, is this interstitial lung disease, right? And if it is, what's causing this? So the next step here is to do a high resolution CT scan. Now, many people think, oh no, why don't we stop the methotrexate? Could this be a contributor to the lung condition? You may be right, but this is not the case because there's so many things that can cause interstitial lung disease. Your rheumatoid arthritis can cause this, causing rheumatoid associated interstitial lung disease, right? Methotrexate can, in some ways, cause some pulmonary fibrosis as well. But you don't know what's causing this. You don't know if you want to stop methotrexate just yet. So you request a high resolution CT scan. Now, this is very, very different if this person has acute shortness of breath that started a few days ago from starting methotrexate. Because in those situations, you're thinking about methotrexate pneumonitis, in which case you stop methotrexate right away. So the key thing in this question is understanding if this is acute or chronic. If it's acute or subacute shortness of breath within a few days or weeks from starting methotrexate, then your answer should be stop methotrexate immediately. You can do all your investigations later, but you need to stop methotrexate immediately because life-threatening methotrexate pneumonitis must be excluded. However, if the symptoms were chronic, you got this progressive breathlessness that occurred after months in a patient that's been taking methotrexate for a long time and having rheumatoid arthritis for a long time. You would then need to do a HRCT, a high resolution CT chest scan. Now, this is to confirm interstitial changes and consider other potentials such as rheumatoid-associated interstitial lung disease. Now, in many cases, you may choose to even continue methotrexate in this sort of picture. But the key thing is, first thing to do is get a HRCT chest first. Now, in our courses, this is what we try to do. We try to make it simple for you. We put tables there. We give you information that you need to know rather than, going through too much of it. So we only try to aim at what we believe is needed for the exam. And I can tell you this, Adam and I have studied this exam for the last 9 years. Yeah, we know this exam as much as we can. We try to understand it based on the GMC specimen questions and everything that we've learned from this exam, we bring to you on the course and also on this free webinar. So, learn from us, guys. All right. Next question.
Okay, so to take a break from ECGs and hearts, let's mix it up a little bit. Great. So that's over 60 seconds to answer the question. So if we have a look now, in essence, you've got bitemporal hemianopia. You've lost the outer part of your vision. And remember, that really only occurs when you've got compression of the optic chiasma by something associated with the pituitary, usually an adenoma. And they've given you enough in the question to think this is acromegaly, right? Now, it's all about understanding what acromegaly is and how growth hormone affects your glucose homeostasis. Because knowing what is produced from the anterior versus the posterior pituitary, very key, but also its function. So growth hormone is produced from the anterior pituitary. It then goes and stimulates the liver to do gluconeogenesis and glycolysis to increase your serum glucose for growth, metabolism, and everything fun. Yeah. And then you get a negative feedback when your glucose level is high, a negative feedback to the anterior pituitary to say, thank you, mate, we've got enough glucose, turn off the growth hormone release. However, in acromegaly, you lose that negative feedback. Yeah. So, doing an oral glucose tolerance test where you measure the growth hormone and then you give 75 grams of glucose and assess the growth hormone level 2 hours later. In a normal person like myself, I hope, you would have a certain level of growth hormone, but then you would have a reduction following the glucose load because you get that negative feedback to the anterior pituitary. In acromegaly, you'll have a certain level of growth hormone that will not suppress and maybe stay the same or go up following a glucose load. Also, growth hormone increases the chance of type 2 diabetes, and therefore we can identify diabetes on the oral glucose tolerance test. Note the question says, what is the definitive test? How can I make the diagnosis? And that is an oral glucose tolerance test measuring the growth hormone measurements. Measuring a random growth hormone is irrelevant. You need a dynamic test because it doesn't matter if the growth hormone is here, here, or here. You don't know if that is abnormal. Yeah. And doing an oral glucose tolerance test with just glucose measurements, you'll pick up type 2 diabetes, but that isn't the underlying diagnosis. For those who chose the short synactin test, that's Addison's disease. You're on the wrong disease. And insulin-like growth factor, which I know people were tempted by, is a screening test. So patients that go to Z saying, look, from my wedding photo, my face is very different. My shoes are not fitting. My tongue hurts. I've got carpal tunnel. I'm hypertensive. Z will do a screening test to say, okay, what's the likelihood of you having acromegaly? And if the insulin-like growth factor is raised, then you get referred to endocrinology for a definitive test, which is the oral glucose tolerance test with serial growth measurements. So this slide is just saying the key things. Don't measure growth hormone randomly. It's not useful. We need to see in a dynamic test. And it will be usually suppressed by glucose because of the action of growth hormone, which increases serum glucose level. And in acromegaly, you do not get that suppression once you get that 75 grams of glucose. And remember, if you're given a question that's demonstrating bitemporal hemianopia, think, is this acromegaly? Is this a prolactinoma? It's something pressing the optic chiasm. So just to clearly highlight why you choose one rather than the other, someone presents to you in clinic with symptoms of acromegaly. You want to screen to assess, is this likely? Because if insulin-like growth factor is normal or negative, yeah, they do not have acromegaly. But if they have a high insulin-like growth factor 1, you then go on to do a diagnostic test. And the question very clearly said, what is the definitive test? What is your diagnostic test? Then you do an MRI to localize the tumor, and acromegaly specifically is treated with surgery, choppy choppy, compared to a prolactinoma, which is always medically treated with carbergoline. That's a prolactinoma. Acromegaly is treated surgically.
And our next question. All right, stopping the poll in three, two, one. Sharing the results. And your answer is B, ureteric stenting. Now, this patient here has a fever, a stone. It doesn't really matter what size of the stone because there is the presence of hydronephrosis. This stone is obstructing the urine from coming out, which is causing this patient to go into acute kidney injury. The creatinine is high, EGFR is low. Of course, we don't have a baseline here, so we can't really compare, but I think you get the point that this guy is going into AKI. Now, ureteric stenting is the way forward here to try to decompress the collecting the, 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 the the renal pelvis, right? So the idea here is you want to decompress the renal collecting system. And you do this because the urine can't come out. Now, your first thing to do is to drain the urine, not to remove the stone. The stone can be left there for another week. It doesn't really matter, right? Aim to remove the urine first. Then later think about removing the stone. So this is a urgent thing. This is going to book up your emergency theater, and the urologists are going to come in, put this patient on a GA, and do a ureteric stent. Now, any patient with stones, obstructive uropathy, which means your hydronephrosis, plus your fever or AKI, you need to pick a ureteric stenting or a percutaneous nephrostomy. Both of these would decompress the renal collecting system first. They don't remove the stone, you're just decompressing the renal collecting system. Now, you can do this by this is the percutaneous nephrostomy tube. You go through the skin. This is done by interventional radiologists under local anesthesia. So you go through the skin using ultrasound, and then you poke in, and then you put the tube in, and you drain the urine. The stone can still be there, but you're draining the urine. Then later on, you book this patient into an elective surgery to remove the stone. Or you can do a ureteric stenting like what we did in the patient above, where we put the tube in all the way up to the renal collecting system and we drain the urine, right? The stone can still be there. We bypass the stone. The stone's still left there. We don't have to take the stone out right away. But at least we've drained the urine and now we can take our time to remove the stone. Now, in the past, I have really gone deep into trying to differentiate when to pick a percutaneous nephrostomy and when to pick a ureteric stenting. But looking back at the level of the PLAB 1 exam again, I think this is unnecessary. I think all you need to remember is one of these options will be there, whether it's ureteric stenting or percutaneous nephrostomy. One of them will be there, which is the correct answer for draining the urine in someone with a stone, obstructive uropathy, plus a fever or an AKI. Now, the most common mistake that I see candidates make is they confuse percutaneous nephrostomy with percutaneous nephrolithotomy. Ostomy is the artificial opening. So this is where you drain the urine. You're not removing the stone. Whereas percutaneous nephrolithotomy, which is option C in the previous question, I believe, that is the surgical removal of the stone. Again, you don't need to remove the stone here. You just need to drain the urine first. Think about removing the stone at a later date. This way, you don't block the emergency theater, and then that patient with an ectopic pregnancy can't go in because you are spending so much time trying to remove a stone. So this is why we always drain the urine. Think about taking the stone at a later date. The stone might even come out, by the way. So you never know. Good. Next question.
Okay, here we go. Lovely. People seem to be a lot more clear and comfortable with this type of question. In essence, I'm just making sure you know the difference between active and latent tuberculosis and the investigations required. And so, for example, let me just bring this up. I mean, this patient is clearly at risk. They're in prison, they're a vulnerable adult, and they've got productive cough, fever, and night sweats. And then you've got the apical consolidation, right? Very classic. This sounds like TB. And so we need to do an acid fast bacilli smear to identify active TB. There's absolutely no place for the MAN2 or the interferon gamma test because they look for latent TB. In essence, it's likely that these are going to be done in the context of wanting to start a biologic agent for an autoimmune condition, like adalimumab for Crohn's disease, or for somebody who is migrating to a different country or starting in healthcare. Yeah. A bronchoscopy is only going to be useful if you cannot get sputum. And so that would only be used if you have to kind of get sputum or get a tissue biopsy. The
I
So
got
when it
you.
comes to active TB, they have active symptoms. The X-ray is typical, which is usually cavitation consolidation at the top of the lungs. You want to get sputum to stain for acid-fast bacilli, but don't be fooled. Sometimes it's referred to as a Zeal-Nielsen stain. So don't be fooled by that. It's the same thing, an acid-fast bacilli smear stain, but they may call it a Zeal-Nielsen stain. There's no point just culturing it because that can take weeks and weeks and weeks. By that time, the patient's got more unwell and infected everybody. And I've already talked to you about the bronchoscopy. For those who may be more senior doctors in infectious diseases or respiratory, there is something called a gene expert test, basically a nucleic amplification test, similar to what we do for chlamydia. However, NICE guidelines recommend it is only for those that would change the management by getting an immediate result. Yeah. And those patients tend to be those immunocompromised or very young. I've not seen a question come up about the gene expert test other than an expert asking me at one of the courses. So I added it to the course and I didn't want to seem silly. And it is in a nice guideline, but I cannot see it coming up. But I love adding just a little bit of clarity just to make sure it's there in your memory bank just in case. But if you want to know about active TB, they have symptoms. They're usually a vulnerable adult in prison, in homeless, overcrowding, and it's acid-fast bacilli, or it may be called Zeal-Nielsen stain. The latent TB is about TB hidden, sleeping in your lungs, causing no symptoms whatsoever. And the main context now that we use it is people migrating to a country where there's a requirement to rule it out, or those wanting to start a biological agent, adalimumab, infliximab, certolizumab, all the mAbs, yeah? Your first line would be your MAN2 test, yeah? However, those who have been vaccinated against TB with the BCG, which is not routine in the UK, we would use an interferon gamma test in that sense because you can get a false positive with the MAN2 test if you've had the BCG vaccination. So it's important to understand that BCG vaccination is not given to everybody in the UK. But in the question, if you're talking about MAN2 test, as we said, people who are healthcare workers or household contacts, you use it. But if they've been vaccinated, you're going to use an interferon gamma test. But in asymptomatic individuals. But my favorite thing to take away from this is you all did very well in the last question, which is good, which means I don't need to focus too much on active versus latent. But the treatment of TB is brilliant. There's so many things you can ask about in an exam because each drug has its own complications and side effects. So rifampicin gives you orange-red secretions. So you may find your sweat stains your shirt or your contact lenses because it's orangey red. It's also hepatotoxic, so it can increase the chances of having deranged liver function tests. And it's an enzyme inducer. It speeds up the metabolism of drugs that are broken down by the cytochrome P450 pathway. So rifampicin would speed up the metabolism of warfarin, leading to a lower INR, or speed up the metabolism of the combined oral contraceptive pill, leading to someone getting pregnant. Isoniazid is associated with peripheral neuropathy. And so a question could ask you, what can you add to reduce that risk? And the answer is B6. Pyridoxine reduces the rate of peripheral neuropathy when patients are on isoniazid. Lovely examinable question. It can also be hepatotoxic. And it can lead to drug-induced lupus, more of a cutaneous kind of form of lupus, where the answer is stop the drug. Yeah. Remember the antihistone antibodies associated with drug-induced lupus. And isoniazid is an enzyme inhibitor. It slows down the breakdown of certain drugs, like warfarin. So there's more warfarin in the system to inhibit factors 2, 7, 9, 10, protein C, protein S. So your INR is higher. You see how our questions now start to link and you get that kind of spiral curriculum supporting you, building on the knowledge that we're working on. Pyrazinamide increases the chance of acute gout. And acute gout is really nice to examine because you know the crystals you're looking for, the joints that it affects, and how to manage it. And then ethambutol can increase your risk of optic neuritis. And so it's so important you assess visual acuity with a Snellen chart and color vision with an Ishihara color plate, because the first sign of optic neuritis is loss of red color vision.
Now, you have 20 seconds to answer the next question. It's going to be a speedy one, right? So I really want you guys to answer quickly. I'm only going to put a timer for 20 seconds and then I'm going to stop. Everybody ready? Now let's go. We're launching the poll. 20 seconds. And stopping the poll here in three, two, one. And in the poll, sharing the results. See, this is the one that a lot of you are going to get correct. But the strategy here is time management. How fast can you get this correct? The answer is intussusception, right? These are questions that you need to take 20 seconds at most because you need to give yourself more time to do the epidemiology questions or the genetic questions, which you should be doing last in the exam. Now, we are here to teach you not only clinical management, not only clinical knowledge, but also time management strategies to pass the exam. And this is one of them. When you see drawing up of his knees to his chest, currant jelly colored blood, you know that this infant has intussusception. There's nothing else. These are very classic clues. Yeah, intussusception is the folded in section of the bowel, and you're looking for key words like jelly blood in stool, sausage shape or mass, not the olive shape. When you talk about olive shape, that's going to be your pyloric stenosis. If they don't say what shape, then you're looking for other factors like is there any blood in the stool, for example. Now, when you talk about intussusception, you start to get hungry because you think, oh man, it's almost lunchtime. I'm gonna get some sausages, some jelly, maybe even some donuts. Yes, when you do an abdominal ultrasound, you sometimes see a donut sign, also known as a target sign. This here is the investigation of choice. Of course, a bowel enema can also be done, but if you were asked to choose an investigation, an abdominal ultrasound would be better. Now, I'm not gonna go through the details of why it's better because we don't have a lot of time, but all you need to do is memorize that abdominal ultrasound is the first and best investigation to do for intussusception. Treatment, this is much lower yield. Of course, you still need to know this. Air enema reduction or laparotomy is the treatment. But the high yield one is how do you diagnose this? CT, ultrasound, barium enema, X-ray, what do you do? And the answer is ultrasound, whether it's initial or most appropriate. In this case, it will be an ultrasound scan. So, now we are going to have one more question at the very end, but we do also want to throw in some tips on how to pass the PLAB 1. So stay with us until our last question. But a lot of people are wondering, I've got maybe a month more before my exam, or some of you are sitting for it in February. Well done, you have plenty of time to study for this. Good work. But what is the best strategy here? In my honest opinion, the best strategy is to complete the question bank first. Now, these are questions that my whole team, including myself, have written. I write the majority of these questions because I'm a GP, and then we've got Adam coming in, and Hannah's in, and a lot of a wider team as well helping with these questions. Now, in total, we have about 5,180 questions. And we remove questions that we think are old, that are unlikely to be asked. So the amount of questions will always be about this. Because for every question we throw in that's new, we take an old question that we think might not be asked anymore, or something that's low yield, or something that you probably don't need to know. Then we take those out, right? What's important is to complete the practice by category section first and flag your questions. Check on your flag questions every single day. Don't just memorize the answers, read the explanations because GMC can twist questions. They like to do that, right? So you need to understand the explanations on what what happens if this is twisted. What do I answer then? These are really key things. So read the explanations. Take time, 5 minutes to read each explanation. Understand the questions. Now, I honestly think you only need to do plannable question bank, and that's good enough, right? But the key thing is not to get fooled by weird, strange question banks, which you think, would this be beneficial? Do I need to have two question banks? And my honest opinion is no, you don't need two question banks. But if you were looking for a second question bank, you really want to concentrate on is this a question bank done by GMC registered doctors? There are a lot of companies out there who do question banks that are run in the US, right? And they're not GMC registered doctors. They have no idea about the PLAB 1 exam. They just pretend to know. They try to cater for PLAB 1 and they sell it as if they know a lot about PLAB 1. But you get so many mistakes there. So avoid those. Look at the company. Is it registered in the UK? It would be very bizarre for a company who's catering for a UK exam to be held or running somewhere else, like US, for example. That would be strange, right? Because the US is all about USMLE. So if you see that, that would be strange, right? And why is this important? Is because you get a lot of information that's wrong, outdated information, information that might be copied from other question banks to throw in there to fill in the amount of questions they have. So be very, very careful on the study material that you pick. Now, on top of that, we've got the 4-day revision course, which Adam is going to tell you a lot more about.
Absolutely. I mean, I fully agree with Z that actually the plabbable question bank will give you the breadth of exposure, not just to questions, but to the detailed explanations that Z's worked so hard on. But we felt people wanted more intense, expert guided revision. And so we developed a 4-day revision course where we've spent 9 years optimizing our slides, creating summary tables, and adding bits and pieces as new guidance have come out, as candidates have said, I need to know this, looking at recalls and previous questions, as in what came up. Are we definitely teaching the right thing and to the right level? So we tinker with it and ensure it meets the needs. The 4-day revision course is an intensive, expert-driven revision course, which is dedicated to PLAB 1, the only course taught by NHS doctors and supported by people who have actually sat the PLAB exam. And the course also comes with a big mock exam. So me and Z, we write 180 new questions just for you to attempt in exam conditions. It's really nice and it gives you the best idea about how you will cope in the exam. Because once you've done Plabbable and you've got that knowledge and experience, doing more questions that you've already done is just remembering the question. And so by exposing yourself to new, never before questions really gives you an understanding of, are you ready? And by giving you access to the expert consultants who teach on this course, it means you have a support group with a WhatsApp group. You have access to the experts to give you some tips in clinchers, and you get access to all the revision slides that we give you. And we're really excited to be running it in October, between the 23rd and the 26th of October. Of course, being part of the whole 4 days is key. But if you miss a day, you get all the slides. You are part of the WhatsApp group. You can message us. And so it isn't essential, but for those who are unable to do 4 days, but it is really good. And it has a very, very high pass rate. So, as I said, detailed revision slides continually updated, summary slides telling you how to differentiate, like differentiating Addison's, Conn's, and Cushing syndrome, differentiating acute lymphoblastic leukemia compared to CML, AML, and all the other different leukemias, lymphomas, the things that really trip you up. We include practice questions to really get you into the zone. And we use a lot of kind of support group building one another. So you're all working towards the same goal. And you have a group to ask questions and share your uncertainties. And that's where the dedicated WhatsApp group comes in. You get the slides. And so once we've done the revision, you can go back to it. You have your summary slides to review and plenty of post-course support with the lecturers to help guide you in your revision, give you individualized feedback about how to approach the exam. So we're really proud of this course because it helps people get through the exam who need a little bit more hand-holding support or sometimes just a kick up the bum in terms of intensive revision because you can't motivate yourself. And then for those who just want that key thing I've mentioned, which is that unseen questions that are not part of the question bank. We also offer all the big mocks available, with the most recent big mock part of the 4-day revision course bundle. And so there's savings there because you actually gain the new big mock as part of the revision course.
Good. Now we have one last bonus question, which I'm going to show you in a second. But just to answer some of your questions on WhatsApp, there's one question here which I want to address. Z, so if we are doing the November exam, what is the best strategy to take to do now and in such short time? Is it gems? Is it mocks? The answer is practice by categories. That is your main thing first. And you can, if you don't have time, you don't need to read the revision guides. You don't need to go through gems. If you don't have time, just do questions. That's the main thing. 50, 100 a day. As you get faster and faster, you realize you're getting about 110, 120 a day. That's good. Now, practice by category should be your main thing. Once you complete that, time mocks, which are also available as part of your subscription, should be the next thing. Only if you have time, you go through jams and the revision guides and everything else. But if you don't have time, just concentrate on your questions. That's the best advice I can give you. Now, one last bonus question there. I'm gonna share this slide. Open the poll here. Stopping the poll here in three, two, one, and in the poll, sharing the results. A is your answer. This patient has chronic kidney disease, type 2 diabetes, hypertension. But one thing to look out for is that he's already on ramipril. So those who answered C, that's absolutely wrong. You don't add another ACE inhibitor to someone who's already taking an ACE inhibitor. So make sure you don't miss those words, right? That's why sometimes you need to double check your work. Don't walk out of the exam once you finish your paper. Come back, reread those questions. You might find that one or two words that you didn't see the first time you read this. Now, this patient here has a HbA1c that is high, EGFR that is low. What would benefit in his case is an SGLT2 inhibitor, something like dapagliflozin, for example. Why would this benefit him? It's because this would help reduce his HbA1c because it's a diabetic medication, and it's also renal protective and cardiac protective as well. So this is a fantastic medication, right? You tend to use this after metformin, and so he's already on metformin. Although metformin and SGLT2 inhibitors under 9-CKS are considered first line. The patient's HbA1c is 58, so you do need to start a new medication. Remember that even if this patient's EGFR is low, like 46, for example, SGLT2 inhibitors can still be used. It may not be as effective because it needs the kidneys to be working well for it to be very effective for reducing HbA1c. That's fine. It may not be very effective for the reduction of HbA1c, but it's still very effective for renal protection. Yeah. So that is an important thing to remember. And this is obviously quite new over the last few years. We really see SGLT2 inhibitors coming up uh, uh, and in some sense, it's like your second pick after metformin for majority of type 2 diabetes. Now, that is it on our side. We thank you for joining this free webinar. We wish you all the best for your exam. We hope that you join us for the course that we have in a couple of weeks. If you have any questions at all, you're more than welcome to ask us on the WhatsApp group, and we can answer back by doing a voice note or typing back. Or you could also email us at course@plabable.com. Now, to answer just one or two more questions that are coming in, can I use a calculator during the exam? The answer is no, you will not be allowed to bring a calculator. Everything needs to be done in your head. You will be able to write on the question paper. So you remember the question paper is going to be bin. The answer sheet is going to be given back to the invigilator. So you'll be able to write all your mathematic calculations and whatever you need, your formulas, all on the question paper. So that you can do, but you do not have a calculator. Lab values are obviously going to be given as part of your questions. I would say you probably want to memorize the very basic ones, your ABGs, your full blood counts, your UNEs. Obviously, memorize certain values as well, like your for example, uh, your restrictive lung disease, what FEV1/FVC ratio you need to remember for that, because they're not going to give you the normal values for those. You might get normal values for lab values, but you're not going to get normal values for your FEV1/FVC. And you can see this. Look at the GMC questions, right? Look at the GMC specimen questions that GMC has already on their website. Google this, GMC specimen questions. You're going to be led to the GMC page. And I'll give you an example off the top of my head, right? I can remember these questions. Question 46 on GMC specimen question. That question has an FEV1 FVC ratio. And you can see that that question does not have a normal FEV1/FVC ratio. It has a the value of it, but it doesn't give you what is normal and what is abnormal. So you need to memorize those. Yeah. And we are here to teach you those in our course and our free webinar. And so we hope that you all join. We wish you the best. Adam, any other last words that you want to say before we go?
No, thank you for joining. Good luck in the upcoming exam. Hope to see you on our resources, but regardless, good luck, and I look forward to working with you in the future in the UK. All the best, everybody. Good luck, and see you soon.
All right, everybody. Bye now.